All right, so I'm recording on my side, so no concerns about that if you don't see the recording thing. Your voice will show up though if you talk, so just FYI if you don't want that to happen. I guess it doesn't have to, but this will be easier if you guys like help participate in the journal club goings on. I think mainly because it'll be a little bit more interactive, and if you can even like if I ask you a question and you get it wrong, like of course yes there are wrong answers, but that's I'd rather hear a wrong answer so we can like correct things because I bet a lot of other people are also wrong about the same thing, and so no judgment here. This is like a new skill for you guys, so like I'm totally not worried about anyone having a wrong answer. I'm not going to penalize anyone for that. But what I want to do with this section of the course is basically spend about an hour or so. We'll see how fast we get through it. Reviewing an article, answering some questions, and then basically seeing like how do we approach an article? Like how do we actually approach and apply the things that we've learned from class, and how do we basically dissect and try to take away something useful from these articles here. So there also was a set of review questions you should also see that was posted there. In the future, when we do these, it will be a group-based activity. So I'm actually going to break you guys up into individual groups, probably like 5 to 6 people or so, and you'll all have your own article. And basically, you'll go through and answer these questions, which you should be able to do fairly easily once we kind of get some practice with this. And then you'll actually turn this in as a group, so that way everyone gets credit. If you look at your syllabus, like the group activity is like 40% of your grade, so it's actually kind of nice that you have this much of it kind of being boosted up by these activities here. So I encourage you to take it seriously, and hopefully you get some utility out of it, because you'll be doing a lot more of this in the summer when we do our research methods course, and you actually have to write your own research paper. A lot of these same skills are directly transferable to that, and then you'll do it a lot on rotations too. So if you have like preceptors that ask you questions or ask you to read an article, something like that, stuff definitely does come up. So without further ado, and again, feel free to pipe up if you have questions, if you have comments. I don't mind interrupting me by any means. I will definitely stop. So we went through and you guys did that little quiz to figure out what you guys are most interested in, and so I picked the top winner here, and it looked like behavioral health was the winner. And of course I'm a drug guy, so I like drugs, and so I went ahead and pulled a drug article. But this is actually from JAMA Psychiatry. Anyone know who JAMA is? Like a person?
Isn't it the Journal of the American Medical Association?
Absolutely, yeah. So one of the things we'll learn about, especially in the summertime, is that like not every journal is created equally. You're gonna find that there's like some really high profile, big name journals that are really hard to get into, and then there's some like smaller ones that may be more niche in terms of their what they cover. So, for instance, like you can have just toxicology journals, you can have just orthopedic journals, which may not have as wide of an appeal, but is more specific to like a discipline. And then even within that, there's varying degrees. You can have really kind of like less prestigious sort of journals, whereas stuff like JAMA is like the cream of the crop. Think like New England Journal of Medicine, you think JAMA, you think Nature, like these are like big deal journals. So if you get published here, you're kind of a big deal. And so this is an example of a spin-off of JAMA Psychiatry. And so they were looking specifically at the efficacy and safety of intranasal S-ketamine adjunctive to oral antidepressant therapy in treatment-resistant depression. So while again not super catchy, it at least is descriptive in terms of what specifically they're looking at, right? And of course, we talked about sort of how you can break down a journal article into its various pieces. You can see here how we have the abstract, where basically they give you sort of the 2-minute read through to get an idea of what they did, what interventions they made, and what they found. They give you the results here. And then we can look down to see things like the introduction, where they talk about why this is an important thing to look at. They talk about the methods, about who they brought into the article or who they brought into the study, how many people they recruited, how they designed it, all of that stuff. And then they get into talking about the results, where they will then have all their graphs and figures and whatnot. They'll talk about the discussion, and then finally their conclusions at the very end here. You can see down at the bottom, right? So that's it. We're done. We're done with the journal club. Good. I'm just kidding. No, we're not. I just want to at least show you sort of the bones of the article and kind of how we're going to be tackling this. So the first question that comes up on the review questions here is like, what's the hypothesis of the study? I don't know if anyone had a chance to really look at it yet, but basically what they were doing in this thing, and you'll learn more about this in behavioral health next semester, but the problem with treatment for depression is a lot of it relies on pharmacotherapy. Certainly there's a non-pharmacologic component to it, but it's like notoriously difficult to like really get a good clear-cut answer of like, do these antidepressants work? And frequently they don't, right? Not only that, but there's a really strong placebo component to this. You can enroll somebody into a study and say, I'm giving you an antidepressant, and it's a sugar pill, and their mind will say, I'm doing something good for my depression, and it gets better. So because of that, there's a strong placebo component to it. And it's really difficult to tease out like what's effective, what's not. And then even when we do look at the articles that are just looking specifically at conventional antidepressants, they have a strong failure rate. They have a pretty high failure rate. So it's definitely a disease state where we could have some improvements, right? We can find some better ways to treat this potentially. Now, is anyone familiar with the drug ketamine? Has anyone ever heard of that before? Or like maybe any sort of like notoriety to it by any chance? Special K. Okay, so I'm asking questions not necessarily from a yes no perspective. I was hopefully having someone like elucidate on that. But yeah, so common party drug. Kyle, I'd like to go hang out at your parties, I guess, maybe. It sounds like you have the good ones to go to. Yeah, so ketamine is kind of has its role as a veterinary anesthetic. It's like, you know, you ever hear it's called like a horse tranquilizer. Yeah, Jackson said analgesic and also often used in peds for sedation. Yeah, so it's a really good drug for procedural sedations. So if you need to, like, for instance, if you have a kid who, has a displaced fracture and you need to set that in the ER, we'll frequently use ketamine. It's a really good drug for that. But what's interesting, yeah, I've seen it given for shoulder dislocation, absolutely. So a lot of different kind of short surgical procedures where maybe you don't want the patient to be so sedate that they don't breathe on their own, right? So this is really good because it kind of helps keep the respiratory drive intact. But they wanted to look to see like if one of the enantiomers of ketamine could be used for depression. And so if you look at the name here, you can see they're looking at S-ketamine, which if you recall, we talked about enantiomers and racemic mixtures. If you took the racemic ketamine and took out, there's S-ketamine, which is the left-handed form, and then you have R-ketamine, would be the right-handed. They're looking at the S-ketamine. And you can see here in their introduction, they talk about the fact that, you know, it's difficult to treat major depression, and they're looking at ketamine because it has a role. It kind of has a novel mechanism. A lot of the drugs that we use to treat depression have to do with serotonin. They say, well, if you boost up serotonin levels, then you fix depression. And it's not quite so simple as that. There's a lot of other things going on that we don't really know about. But what's interesting is that S-ketamine actually works through a novel mechanism. It actually works through the NMDA receptor. It's actually an antagonist at that receptor, so it actually blocks glutamate. If you're familiar with glutamate, it's a very strong or neurotransmitter. It's very excitatory in nature. Kind of think about GABA as being the brakes on your brain, and glutamate kind of being like the gas. And so this is trying to block that to some degree. So first off, starting off, they're saying, okay, this actually you can go back up here to the introduction just to figure out what the hypothesis is. So what they're saying is they want to assess the efficacy, safety, and dose response of intranasal S-ketamine hydrochloride in patients with treatment-resistant depression. So we're going to need to come up with some, you know, definitions for this stuff here. But right off the bat, like, what do you think their hypothesis is? Any ideas?
To see if it's an efficacious treatment option for those with drug-resistant depression.
Good. Does it work? That's you know, you could break it down to even as simple as that. Thank you, Isabel. So basically saying like, you know, is for people who have treatment-resistant depression, is this a useful adjunct, right? So based off of that, what do you think their null hypothesis would be in this article? Just based off that, what we know.
There's no effect.
Yeah, it doesn't work, right? It basically has no additional benefit to treating treatment-resistant depression than if you gave the patient placebo, right? So that's going to be their null hypothesis, and they're not going to state that out there. No article is generally going to say our null hypothesis is blah, but you should be able to intuit what that is based off of what the premise of the article is. Okay, so going on. So what is the design of this study? So let's get down there to talk about the design here. So I said this study. We'll talk about the patients actually enrolled here. So if you look at the design section, this is where you can figure that out. They say this is a phase 2, 2-panel, double-blind, doubly randomized, delayed start, placebo-controlled study. That's a lot. right? So we can kind of break down some of those components and to make it a little bit more reasonable. So first off, phase 2, does anyone recall what that means in terms of like drug development? Talk about clinical trials for medications. This is like a new drug.
This is the part when they're in the testing of it.
Very good. So they're doing it in, they did phase 1 trials. They want to figure out the kinetics of the drug. They want to figure out all that. And now they're getting into phase 2, which is going to be where they start to test it in people who actually have depression, which is what the indication they're going for, and trying to see, like, does it actually work? Is it safe and things like that? So that's what they mean by phase 2 trial, right? Because this was published in 2018, so it's still a relatively new journal article in the grand scheme of things. Usually we consider new to be like within the past 5 years or so. And so we're going to get into talking about the other thing. So when I say double blind, what does that mean?
The participants and the people running the study both don't know who's getting what.
Very good, Nicole. So the patients don't know what they're getting, if they're getting placebo or the active drug, which will be interesting. We'll talk about the blinding process here in a little bit since it's an intranasal medication. And then also the actual people running the study don't know. So the actual providers who are enrolling and doing follow-up with these patients don't know either. Why do you think it's important to blind the researchers?
Bias. Oh, sorry.
Yeah, no, all right. So what kind of bias could the researchers introduce here? Okay, leading questions, that could be one thing. What else?
Their demeanor could be like really hopeful or something to the patient.
Good, yeah. So they could be hoping that this actually works. And you'll see it with a lot of the scales that they use for depression, especially, like you're asking the patient questions, like you're getting subjective sort of questions or answers from them, as opposed to like measuring blood pressure. It's hard to really skew blood pressure, it's just a number, versus if you're saying like, well, what's your rating you're feeling today on a scale of 1 to 10, 1 being depressed, 10 being great, something like that. And so by sort of having that inherent bias of, if you want the drug to work or not, it introduces some complications. So by blinding both sides of the equation, you keep it so that no one knows what anyone's getting. You may have some ideas. You may have like I mentioned, my dad was enrolled in that COVID vaccine trial, and he's like, I'm pretty sure I got active drug. There's no way you could really do a placebo shot and feel as miserable as he did afterwards. But maybe mind is more powerful than he thinks, and maybe actually has a psychosomatic reaction. Who knows? But probably unlikely. Anyway, but the blinding process is really important too. So for instance, if you had like tablets and you wanted to blind a set of tablets between active drug and not, you just make them look identical. But that can be challenging depending on the intervention. We'll talk about the intranasal administration here in just a little bit. Okay, so we'll look at the doubly randomized, but when I say randomized, what do you think that means? In the context of like this article.
The people given the medication was random, like you either got the placebo or the medication at random.
Yeah, so remember, and again, is this a prospective or retrospective study based off what we know so far?
Prospective.
Good, yeah, so this has to be a prospective. If you're going to be randomizing patients into either group, you're setting up whether they were exposed to the risk factor. And the risk factor here is whether they got esketamine or not, right? So they're being randomized. They'll talk about the randomization process. Usually it's like pretty complicated stuff because to get true randomization is actually quite difficult if you look at it from like a stats perspective, but I'm not going to get into that right now. So good, so patients are randomly set to either group. Again, this is a prospective study, which is what, it's a clinical trial, which makes sense they would do that. And then it says placebo controlled, right? So again, placebo controlled aspect is really important here because placebo effect is notoriously bad in especially psychiatric studies because of the fact that there's so much, there's such a mental component to it that if you think you're getting drug, then you're more likely to actually see positive effects. And that's why we try to control for that here. Okay, so we'll talk more about the design in just a little bit, but that's the gist of it. It's a randomized controlled double-blind trial. You could say that and be 95% of the way there. Okay, now one thing you'll notice, they talk a lot about supplements. That's something you're going to see a lot in those really big journals because page space is limited, and so they'll oftentimes publish supplemental things online. So if you wanted to dig into more details, you could, but I don't think we'll need to do that for today, right? Okay, so in this case here, what is the independent variable and what's the dependent variable, and then what type of variables are these? Nominal, ordinal, or continuous? So in the case here, so what do you think our independent variable is going to be based off what we know so far?
The dose.
Okay, so one component of it is the dose. What else is the other component? So did they get drug at
the
all?
medication or you don't.
Yeah, very good, Bailey. Yeah, so did they get drug or not is kind of the other component. And so that's an important thing too. It's not just 2 groups we're comparing here. We actually see there's kind of 4 groups we're looking at least initially. There's kind of a 2 period here, which is a complication, which I'll talk about in a little bit. But you can see here at the beginning of double-blind period 1, eligible participants were randomized 3 to 1 to 1 to 1 to intranasal placebo or esketamine 28, 56, or 84 milligrams. Okay, so that could be considered our independent variable because that's what the researchers set up. They randomized the patients to those groups. The patient had no influence on that whatsoever. And if you notice, it's 3 to 1 to 1 to 1, probably to make pretty even groups between those that got placebo versus those that got active drug there. That's what I surmise from that standpoint there. So if you were looking at this, how would you categorize the independent variable? Would you call that nominal? Would you call that ordinal, continuous? This one's a little tricky.
Would it be nominal because you either have it or you don't? There's like no in between?
So in that case, yeah, I would say so. Whether they got drug or not could be considered sort of like a nominal variable. It could be a dichotomous sort of thing here. But almost you want to look at the 3 groups, 28, 56, and 84, almost as like an ordinal variable because they broke up into groups and there is an order to them, even though we kind of know the the dose itself is a continuous variable. So that one's a little more tricky. I'm not going to ask you tricky stuff like that in the test. It'll be pretty clear cut in terms of if I'm asking about, whether people drove Fords versus Chevys versus Subarus or something. Like it'll be more clear cut if it's like a nominal versus ordinal sort of variable. But yeah, so I'd say it's kind of a blend between those two there. So Jackson's asking, could you express as 0, 28, 56, and 84? You could think of it that way for sure, right? So that totally makes sense here. So let's look at the outcomes they're going to be looking at. In terms, so talk about study drug administration. Okay, so here's where they actually get into what they're interested in. So efficacy, endpoints, and analyses. They said the primary efficacy endpoint is change from baseline pre-dose, basically in the first day of each period, to endpoint of this MADRS total score. Now you guys probably don't know what that is. I honestly didn't know a lot about what it is either, but it's a Montgomery-Åsberg depression rating scale. One of the things you want to look for when you're looking at these articles is you want to make sure that the scales they're using are validated. When I say validated, it means that they have been used in previous articles to show that they are good indicators of whatever you're looking at. In this case here, these should be a pretty good scale for rating depression. And you can see here they put their references. They will show you what articles they're pulling this from and why they're using it, basically. And so if there's no references here, then that should be kind of a red flag. It should be saying, wait a second, are they using a made-up scale? Like that doesn't make a lot of sense. So in this case here, we could look it up and see what that actual scale is and see that it actually is going to be a score, like based on how many questions you answer, how you answer them, you'll end up getting some scores there. And so that'll be important when we actually look at the analysis afterwards to see the change there. So they're looking at an actual point scale. So the higher the number, the more depressed the patient is, and we want to see a reduction. Hopefully if the drug is working, we want to see a reduction. In that case, Sarah, how would you consider, and would that be the dependent or independent variable at that point?
Dependent.
Good. Yeah, it's dependent because that's what's changing based off of the independent that the researcher instituting. So in this case here, how would you, if it's a point scale, how would you consider that to be in terms of a variable? Would that be like nominal or continuous?
Continuous.
Yeah, so that would be more of a continuous scale, the way that they're rating it. Again, with an ordinal scale, that's something where there is no real defined difference between a scale, a point of 1 to 2 or 2 to 3 could be totally different. Just like if you rate your professor at the end of this class and you say, strongly agree that he's totally awesome or strongly disagree and I think he's terrible. There's not a defined difference between those scores there versus here, we're going to consider it to be more of a continuous scale here. 1,000 points for the bad teacher scale, I'm sure, but I'm just kidding. Anyway, so that's going to be our primary outcome here. And you can see that a lot of bigger studies will also have secondary outcomes as well. So for instance, they're also going to look at safety because this is a clinical stage 2 trial. So they want to be able to look for that additionally. But I just want to focus on that main scale there because that's what we're going to look at for our results. Okay, very good. So now on to question 4. So how were patients included or excluded from the trial, and then how were they assigned to each group? We've kind of already talked about one component of that, but let's look at the inclusion and exclusion criteria. This is really important because you want to know, does this apply to the patients you're taking care of, right? So looking at this, they said the study enrolled medically stable based on physical exam, medical history, vital signs, and 12-lead EKG, performed a screening, adults 20 to 64 who were diagnosed with MDD according to the DSM-4, okay? Now, I know the DSM-5 is out now, but maybe at the time, this a couple years ago, maybe it was kind of in between, so they're still using the 4. So right off the bat, like, who could you generalize this study to, and who could you not generalize it to? Is there any group of people that you could not take any actual takeaways from this study and apply it to your patients? That's a kind of bad way to ask a question, but would the results here apply to children? Yeah, so Gaza Peds, so Selena. Yeah, so exactly, very good. So right off the bat, I couldn't say whether or not this is going to be applicable to children, right? So, and again, why don't we look at children in this type of study, do you think?
Probably unethical in the sense.
It's
guess.
yeah, it's definitely more challenging to do ethical studies in pediatrics, or they could be reacting differently than adults. You know, maybe pediatric depression is a little different. Who could say? But generally, from an ethical standpoint, this is a lot easier to do, right? So they went ahead and said, okay, so in when you're trying to say how applicable is this study to my patient I'm dealing with, that's called generalizability, right? And if it's very generalizable, then we can consider that to be sort of robust. That means that the article applies to a lot of different types of people. It's not just narrowing down to just treating like one type of patient that you're only going to run into once in a blue moon. This is going to be applying to a lot of patients. So in this case here, if you're working in behavioral health, do you think a lot of your patients are going to be relatively medically stable and age 20 to 64? Probably. Right? You know, if you work just in behavioral health, that seems like a reasonable assumption there, right? So anyway, so that was the primary inclusion criteria. And they said all participants had TRD, or treatment-resistant depression. So how did they define that? That's another good thing too you want to ask. How do they make their definitions? So they said defines inadequate response to 2 or more antidepressants assessed by this hospital treatment response questionnaire with at least 1 inadequate response in the current depression episode. Okay. So does that sound like treatment-resistant depression? They already failed 2 drugs? I'd say so. If you failed 2 antihypertensives and you're still hypertensive, I'd say you failed that as well, right? So that seems to make sense so far. So otherwise, antidepressant failure from prior episodes acceptable, blah, blah, blah. All participants continued the antidepressants. So this was good to know. They were continuing the drugs that they were taking, even though we said that they're not working necessarily. And so then the other thing they wanted to make sure they excluded for. So this is really key as well, because if your patients meet any of these criteria, then it may not be applicable to them because they were purposefully excluded from the study. So it says here, do they have recent or current suicidal ideation, intent to act, suicidal behavior, homicidal ideation, or intent, right? My wife would not count for that in this study because she'd want to kill me, right? Diagnosis of bipolar or related disorders, intellectual disability, psychotic disorder, MDD with psychosis, post-traumatic stress disorder, OCD, substance alcohol use disorder, all this stuff. So why do you think they exclude all of these types of people?
Dr. Wood, I actually had a question on that.
Oh,
Is
sure.
it
It's because she has
is
to
it-
listen to me talk all day long in the house. So that's probably why she has the homicidal ideation. I'm just kidding.
Oh my gosh. As far as like the exclusion principles for that, would they exclude them because they're worried about making it worse, or it's going to skew the data? I couldn't find like the difference of why they would want.
That's a good question. So one of which is that there's always a concern whenever you start like new antidepressants for patients that there could be an increased risk of suicidality. We see that a lot, especially in children and adolescents starting up like new antidepressants. So that could be one thing, right? They could have said, well, we don't want to necessarily start it if these patients are really unstable from a psychiatric standpoint, right? Or it could be because these patients would introduce bias, right? Because you may only have 1 or 2 patients who had recent suicidal ideation, and if they have a really poor response or a really good response, it could perhaps skew the data. So this is how they're trying to remove extra biases. Now, does this mean that the drug would not work for them? There's nothing to say that. We just don't know based off the study because they excluded them. Keep in mind, this is for a phase 2 trial where they're trying to get a very specific indication from the FDA. So they're saying we want this for treatment-resistant depression, and so we only use it for people who really kind of meet that very specific category. So it could be both reasons to some degree. It could be more so from a bias standpoint. They just want to eliminate any of the extra bias there because, again, they want to make sure that the results are as clean as possible. But that limits the generalizability to your patient. So if you had a patient who has any sort of PTSD, which is actually interesting because there's a lot of literature out there looking at using ketamine for actually soldiers, like veterans who have PTSD, and using it for their condition. So, you know, there's other articles that look at that, but this one is just being very specific. So one thing to note there, okay? So now we know who we got in the study. Now we know who we don't and how they got assigned to each group. We talked about the randomization procedure. I'm not going to really delve too much further into that, okay? And so we talked about the outcome measure of being that change in that scale, right? So it was a point-based scale looking to see like how that changed. Hopefully we see reductions, but we'll see, okay? So other things I wanted to note as well is that they kind of have an interesting study design here too. So I wanted to show you the table they have just to show you how it kind of gets broken down. And it looks kind of, oh, sorry, one more thing I wanted to look at. The sample size determination. Okay, so this is another really important component that not every article will include. Why do we do a priori sample size determination? What does that help us to do? Remember? Power. What about power?
It increases the power, right?
So it helps us to determine how much power we have based on the sample size we're going to get, if that makes sense. So basically this is saying we're looking for a specific effect change, right? We're looking for a specific change. And they say right here, they want a change in this MADRS scale of a 9-point difference. And so they say for based on that difference that we want to see, how many patients are we going to need to be able to show that, assuming that the drug actually does work? Okay? That's why they do power calculations or sample size determinations. They're kind of the same thing because it tells us how many people we need to include in order to find these differences. Okay, and so they ended up finding based off of their calculations and based off things like dropout rates and things like that, because again, people fall out of studies all the time. And notice here they want an overall one-sided significance level of 0.05, and they end up needing 60 individuals to be randomly assigned to the treatment. Okay, so basically they said we need 60 people in the study. If they get less than that, and their study doesn't show any difference between the groups, what could you determine? What type of error could that be? Yeah, so it's underpowered. What kind of error would that be? Type 1 or type 2? Type 2, very good. So if they don't have enough people and they fail to show a difference and they fail to reject the null hypothesis, that's considered to be a type 2 error potentially. We don't know for sure, but we can say that there's a chance. And so even they talked about trying to limit their likelihood of having a type 2 error later on in the article here. So that's a big thing there. Now you notice here, overall one-sided significance level of 0.05. So they're using a one-tailed test. Why do you think that's important here? Why do you think they chose to do that versus a two-tailed test?
Strong belief that the antidepressant will help them.
Yeah, so they don't have any sort of assumptions that giving these patients ketamine is going to worsen their depression. They don't expect their scales to go up in those cases there. So because they assume that it's going to go down, they're going to say, okay, we're going to use a one-tailed test. That makes it easier to find differences if they do exist, right? Because remember, two-tailed tests tend to be more conservative. I'm going to elucidate on that a little bit later on when we do the review here, okay? So anyway, so they said they need 60 people. So let's talk about how they actually got into it. So if you notice here, they screened 126 people. Now, not all of them are going to meet the inclusion criteria and exclusion criteria. So you can see here that 59 failed the screening for various reasons. Either they did not consent to the study, they were unwilling to adhere to the protocol, because again, this is actually a pretty long study. When you looked at it, it goes out to like 180 days. Because they had an open label period. I'll talk about that in a moment. Some of them were suicidal. Some of them had EKG findings that were concerning, all those stuff. So they got rid of all those people right away, okay? So then they get down to 67 people who are eligible. So right now they're already above their 60 that they wanted to randomize, which is a good sign, right? And again, finding people that meet all those inclusion exclusion criteria to fit within that can be difficult. So it's good that they actually found the right number of people, okay? So anyway, so then they randomized it. Remember, it was 3 to 1 to 1 to 1. So they had placebo, so 33 people here, and they had 11 in the esketamine group based on the dose. You can see here, right? So 28, 56, and 84. They'll show you where people actually withdrew from the study, either due to adverse effects or I think the WBP was withdrew because they basically decided they didn't want to be in the study anymore. Now, are patients allowed to do that? Can they just remove themselves from a study whenever they want? They have to be able to, because otherwise you're holding people against their will. So that's a huge ethical thing. So you definitely have to let them come out whenever they want. So for whatever reason, could be anything. Yes, absolutely. So basically they then went ahead and did this. So notice here, this is a 1 week period. They just got basically twice weekly doses for 1 week. They either got placebo or they got the actual drug. Did they read how they masked the placebo to make it seem like the actual drug?
They tried to add like bitterness to it.
Yeah. So they tried to add a bitterness to it to make it seem like it was the actual drug, which I presume that the researchers probably had to do a whole bunch of intranasal ketamine to figure out what it felt like, and then try to figure out what the placebo felt like, right? I'm just kidding, they probably didn't. But they added, basically they went ahead and added the bittering agent to try to mask that. But they'll talk about that a little bit in their limitations a little bit later on. So Matt was asking, would having 12 instead of 11 in the 84 affect the results, having one extra person? Not necessarily. If it does have an effect, it would be quite minimal because it's only one person versus the whole 60. So looking at that, it's just part of the randomization procedure, just kind of what happened. So that's to be expected. There's a little unevenness in the groups there. Yeah, lots of taste testing for sure. So anyway, so they went ahead, and then what was interesting, they had a second period here. Now, what was the point of taking these placebo patients and then breaking them up and randomizing them again? This is that second randomization they talked about. Does anyone know?
If they had other factors that could have contributed to decreased rates of depression to isolate it better.
Well, they basically they wanted to say like more so they want to say, okay, well, if these people that got placebo, we know some of them are going to have placebo effect and some of them will improve with no intervention whatsoever. They didn't want to take those people, and they basically were looking at their symptom severity. So they took the more severely depressed patients. They had to have a scale greater than 11. And then if they were more moderate to severe, they wanted to see what kind of effect they would have. So switching from placebo and then giving them actual drug without them knowing it, does that have any effect, basically? So it's almost like kind of a nested trial within the trial itself, which is kind of interesting. The other people who got that drug, they kept going with the same dose, right? So they basically got 2 weeks of the drug, and they wanted to see, is there a sustained effect of the drug too? It's kind of another thing that we want to be looking at. That part would...
So I have a quick, sorry.
Yeah, go ahead, please.
I had a question. When I looked at this, I was a little confused at how, so they had 67 eligible participants, and then, there's so much like withdrawn. And then at the very end, it says 16 withdrawn, but then there's 60 in the follow-up. And I just don't know how the math works there.
So they define that a little bit. I can't remember where they define it specifically, but they say it is. So that's a very good point. So if you recall, I talked about intention to treat analysis. Anyone remember what that means? Basically, even if people fell off of the study, as long as they had certain numbers, so I think they talked about having like at least a baseline report and then at least one follow-up, they would still include them in their analyses. The point of that being is if you had a bunch of people withdraw because of adverse effects, and then you were left over with only maybe half the patients, and you found these really good results, that kind of skews the data because you're like, well, wait a second, all those other people dropped out because the effects didn't, because the adverse effects are so bad. That doesn't really speak to having a very effective drug. So instead, they do intention to treat analysis where they still include all of those people just to make sure that they still find something. If they don't, then that could be showing that maybe the drug is really not all that effective, versus if they include all the people that fell out, but they still show a difference, and that speaks to it being, you can be more confident in those results. You can be more likely to say, yeah, this seems like it's working. But that's a really good question. Intention to treat analysis is really important. If they don't account for these dropouts, then they're not doing a very good scientifically rigorous study there, right? Brian was expecting your drink to fall out when you drank that because you're upside down. That was pretty funny. So anyway, again, they did this kind of nested randomization here, where people were still double blinded. They still didn't know if they're getting placebo or not. Although it'd be kind of interesting if they kind of detected a difference in the nasal feel of it, I guess, if it was going from their bittering agent to the active drug, but who knows? And then they went ahead and they did an open label period. What do you think open label means?
People know what they're getting.
That's it, exactly. So they went from being a double blinded to where basically now the researchers and the patients know what they're getting. They know they're getting active drug, and I think they end up getting like the middle dose. They got the 56 milligrams basically, and then they followed up to see what happened, right? Just to see if they got sustained effects or if there are any changes, whatever, right? So that's what they were looking for. It's basically how the whole study was designed. It's a little more complicated than kind of what we're talking about in class, but yeah, I thought it was a good example. And again, it at least half of you are kind of interested in the topic anyway. So let's look at the results that they actually had here. I want to get to, you can look at the graphs, right? And it's important anytime you're looking at a graph to know what the legend is, to know like what these different bars are showing you. Because if you look at these bars here, you might incorrectly assume that they're like 95% confidence intervals, but what they actually put here, error bars indicate standard error, right? So that's something to note, is that again, you can't take away the same conclusions there from that standpoint. So they do look like you're seeing a definite decrease in the scale there. So again, looking at period 1 where they got the first week of drug, you can see here it looks like the scale went down, but you notice all of them went down, right? It looks like all of them seem to have some improvement, going to that placebo effect you can see there. And then some of them ended up having, you know, the effects maybe not sticking around for as long you know, as they were taking it, basically. These are helpful to some degree, but I'd rather look at the actual tables where they can show us a little bit more of the details here. Now, one thing they don't include in the article proper is talking about the types of patients they included. So I don't know necessarily, like from a gender perspective or age and things like that, if everything was truly equal. That's probably in the supplements. If they didn't mention it and it's in JAMA, they probably were pretty equal if I had to guess. But it is something to at least consider, right, looking into, because if it was skewed and they had like a majority of females or patients with higher severity scores in the placebo group, then that could have an effect. And so you'd want to know those sorts of things there. So anyway, so looking at the baseline, so looking at their baseline MADRS score, 35 versus 31 versus 33 versus 35, they look sort of similar. So, you know, no huge differences there. And then looking at the actual changes. So let's look at the change at 24 hours. You can see here now, you notice it's a negative number, right? Because the scale is going down. They're having a net decrease in their depression scale. So that's why all these numbers are negative. And again, notice here, they're not putting confidence intervals or anything. They're just putting standard error in the parentheses. So always want to look to see what they're actually defining there, right? So anyway, so this is period 1. That's the first week that they got it. What we're actually interested in is, let's see. They talk about number of responders, remitters. Here we go. So we want to see the p-values here. Now notice it'd be nice if they gave us the 95% confidence intervals, but instead they give us a p-value, so we can just look at it to see if it's statistically significant or not. I like to show the confidence intervals because I think I can teach you more with that. Oh, let's see. Kaylee didn't know you switch from placebo to drug in the same test. Yeah, this is kind of a interesting, more complicated trial than most. So anyway, so what you can see here, so looking at change at 24 hours. So what kind of conclusions can you make based off of this just after 24 hours? Anyone at all? There is a change, correct? Is a statistically significant change?
The 28 and the 84 are statistically significant, but the 56 is not.
Where are you seeing that at? At change the endpoint?
I'm looking at the p-values, unless I'm reading that wrong. Could be.
Yeah, so it depends on which time frame you're looking at. So I want to look at the 24 hours at first.
Sorry.
Yeah, that's okay. Yeah, so what you can see here is that notice that each of these are compared back to placebo, right? And remember, they talked about multiple comparisons tests because, again, this is three separate sort of comparisons they're making, 3 different tests. So they have to account for multiple comparisons. Otherwise, that type 1 error rate's going to go up, right? So you got to be cautious with that. Now, if I wanted to compare all 4 of these groups together at the same time, what could I do to see if there's any difference amongst them? I said them some good p-values right there. All right, yeah, so Matt says ANOVA. That would actually absolutely be true. You could just do one ANOVA to see if there's any differences amongst the group, and it probably would have came up positive, because what you can see here is that each one of these was significant, right? So a p-value of less than 0.05. So it changed at 24 hours. It appears that each of these doses are superior to placebo, okay? So we can say at 24 hours, great. But now do patients have their depression cured in just 24 hours? Well, no, right? We care also about at the end point, right? So if we're looking at a whole week's worth, what do we notice here? We're to look at the change at study period endpoint. Are these changes sustained? Well, let's look at the dose of 28 milligrams. Is this statistically significant? There has to be less than 0.05. So it's right there. So we could say it's trending towards significance, but it does not appear to be statistically significant, right? So we could not say this is not due to chance alone because it's right there at 0.05, but it's close, right? So you can still say, well, maybe if I did a bigger study, maybe I would see something different here. What can you say about the 56 and 84? It appears that there is a sustained drop in their the endpoint, the actual depression scale at the end of the study period. Now, can I say which one is better? Could I say, is the 56 or 84 better? Yeah, they mentioned that before, 0.05. Yeah, exactly. I cannot make that assumption. I can only say this is better than placebo. They had lower scores than placebo. You know, in terms of cause and effect, what kind of trials give me like the most confidence between cause and effect?
Is that experimental?
Well, so yeah, so absolutely. So it's observational versus experimental, but what type of experimental? What type of trial is this we talked about? Yeah, so Jackson said a blinded randomized controlled trial. This is the strongest evidence you have, right? Especially if you have like a really big sample size of showing that of cause and effect. We had people who were randomized to 2 different groups. They were essentially identical, assuming the randomization went well. And I introduced this drug and I saw these differences and they were statistically significant. That is much stronger evidence of cause and effect than if I did like a retrospective cohort trial or did a you know, case control study or something like that. So this is really strong evidence. I would say, yeah, I feel pretty confident saying that esketamine probably has some reduction in depression scale versus placebo, right? If I wanted to compare esketamine 56 milligrams to 84, then that would be a separate comparison you'd have to do. And they didn't find that, so they went ahead, you know, it could be future studies or something if they wanted to, right? All right. They did some other stuff in periods too, but basically that's what I kind of wanted to show you. I want to show you kind of the analysis. Now here we're looking at differences between placebo scale. So this drop of 5.7 here versus say 15.7. So we are looking at a difference, not a ratio. So looking at that, if you were to see a confidence interval, what do you think would be my threshold for significance? If it encompassed this number, then it would not be considered statistically significant. Right, give it the big O, right, 0, because I'm subtracting one thing from another. If both this was 5.7, negative 5.7, and negative 5.7, and I subtracted one from the other, it would be 0. So if this confidence interval included 0, you would not be able to say it was statistically significant. So like this one here, it probably just included 0, just barely, maybe 0.1 or something, right? Because it encompassed that. And again, the confidence interval is probably ranging from like negative 20 up to like negative 2 or something like that, right? It's all negative there. If it includes 0, then it's not statistically significant. Okay, so hopefully that makes some sense. All right, and you can see in the conclusions, it's always important to talk about the limitations of a study, and so this is important here. So notice here they talk about the generalizability of the study findings. It's limited by small sample size. Again, 67 patients, 60 in total they followed up. You know, can you apply that to every single majorly depressed treatment-resistant patient you run into? Probably not, right? But at least this is a good stepping off point. It'd be good for a phase 3 trial as well. So you can think about that. And also the enrollment criteria excluded individuals with a history of psychotic symptoms, substance and alcohol use disorders, recent use of cannabis. Do you think there's a lot of depressed patients that also have these factors? Absolutely, right? So again, it limits the generalizability, but it's a good jumping off point. It looks like the drug works. Now we can expand that out perhaps and try other people to see how it works there. And they also talked about the difficulty of blinding esketamine despite adding a bittering agent. So it can be difficult to do that, and especially with something that you can tell the difference. Like we had one trial where we had to do, the drug was administered intrathecally. I actually had to do lumbar puncture to administer the drug. And so we basically had to give like sham procedures to the patients on placebo so that made sure they felt like they got a lumbar puncture even though they didn't get any active drug. And that was very kind of challenging from a you know, actual technical standpoint. So, but those aren't too common when you see that. So anyway, so that's basically Journal Club. Notice we didn't dive into every single number on here. I just want to get the quick gist of things. Do you guys have any questions about this procedure? Kind of how we went through and identified all kind of the quick highlights of the article itself.
I have a question. So if it's double blind, who's keeping track of who's getting the drug and who isn't?
Ooh, that's a good question. Who do you think is keeping track? Anyone?
The board?
Some
Doesn't the board
rando?
require-
So the
review
institutional
board?
review board, so the institutional review board has to approve everything, but they don't have any hands in actually running the trial itself. So someone said unpaid intern, perhaps, but you want someone who actually knows what they're doing, hopefully. Isabel actually got it right. It's probably going to be a pharmacist, right? So, and actually it's funny because you see a pharmacist right there in the actual author list. Yeah, so frequently, like I got to do that too as part of like my management responsibilities when I was back at Nemours full time, is I would help to coordinate a lot of the randomization procedures, right? I would be basically given a number, and I actually had to call up with this number. So the patient got assigned a number. I got the number. I had to call up the drug company because it was a clinical trial. Called the company, and then I got this I had to do this whole phone verification system. It felt like I was a spy trying to get like codes for a nuclear launch or something. And they would say, okay, you get this box, and this box contains actual drug, right? And so then we'd have to prepare it, and we'd have to take it over to the research coordinators and the providers, and like everyone wants to know, like, oh, is it active drug? Is it? You tell me? And I'm like, I cannot tell you because I can't even like have a smirk on my face, because if I do, that breaks the blinding and can introduce bias. And so that's a major, major no-no. You never want to be someone that breaks the blinding on a study. Otherwise, everyone gets really mad at you. So fortunately, I never did that, but I felt like I was handling like nuclear munition or something like that. I was so nervous carrying it around, trying to keep a stone face. So it was difficult. But yeah, usually pharmacists are the ones that would handle this from a drug perspective. Very good questions. All right, so we got some questions over here too. Good. So that's basically Journal Club. That's what you're going to do in the future when we have our group sessions. So probably be 5 to 6 of you in a group, and we'll break you up. You'll have time to go through it, and then you'll come back and we'll talk about the articles, and we'll kind of go through and see what your summations are, and then we'll actually be able to submit those, and that'll be your group participation. So thank you for yeah, don't make eye contact. Thank you all for being responsive and being interactive. It makes things much more interesting for me at the very least, and of course everything's all about me. So there you go. Just kidding. All right, so let's look at the questions we have here before we get into our actual review for the exam here. So for PowerPoint 5, challenges and statistics, is the family-wise error rate the same, or the name of the mistake is made, and then the Bonferroni Correction is what we specifically refers to how we can prevent the mistake by dividing alpha. That is absolutely correct. So I'm sorry, the family-wise error rate basically refers to breaking up that 0.05 amongst all the different comparisons you're making. The mistake itself is the multiple comparisons, right? So by performing multiple comparisons using a p-value of 0.05 for every single one of them, that's where you run into increased type 1 error rate. When you have a Bonferroni correction, you're now taking that 0.05 and divvying it up amongst all of the different comparisons you're doing, and making it more difficult to achieve significance, but it also helps to limit your type 1 error rate, okay? The Bonferroni is just one way to do that. There are multiples that are out there, so it just depends. Okay, so can you explain why the MADRS score was a continuous variable? That's a good question. Again, because of the way that they're using the scale, they're considering it to be they're basically making it continuous by having it be a point scale like that, to where if the patient answers yes for something or no for something, they'll get a point assigned to it. So if they have no depression, then presumably be 0. I'd have to actually look up the scale itself. Again, if you work in a field, you'll get to become more comfortable with these things. Professor Austin will teach you totally different behavioral health scales as well. So this is just the one they used. But by using it as a point-based scale, and then being able to compare them to other ones, we could do subtraction, we can do addition. And so that can be useful for helping to make those comparisons. So that's why they did that, basically. Okay, with ordinal versus continuous variables, we know that continuous is referring to a series of numbers, but if ordinal also can, like with pain scale, how can we tell the difference? It's a good question. So if there is a defined degree of difference between each of those numbers there, right? So if I go from, say, 4 hamburgers to 5 hamburgers, and I go from 5 hamburgers to 6 hamburgers, the difference there is always the same. It's always 1 hamburger, right? Always 1 point. Versus with ordinal, there can be an undefined difference between each of those categories, right? The only difference is there's an order to them. That's the only difference between that and nominal variables. There's a difference. So if I were to give you like types of cat, and I said Mancoon and Persian and Egyptian, I don't know, whatever kind of cats are, there's no necessary order to those cats. They're just different categories. Versus if I were to say have a scale, and I were to give you an ordinal scale saying you strongly disagree, you agree, you somewhat agree, and if I break it up like that, there's no defined differences between there. Like, how do you like rate a restaurant, and like how do you actually define the difference between giving it 4 stars versus 5 stars? You may have criteria, but it may not be the same for everyone. So because there's no defined differences between those values, that's what makes it ordinal. There's still an order. I know 4 is better than 3, but I don't know how much better that is, right? Or like if you ever look at the dollar signs on Yelp and it says like $1 versus $2 signs, like what does that really mean? You know, because within $2, it could be quite a bit of difference there. I prefer the $1 sign mostly, if you ask me, but also don't go out to restaurants anymore because we live in 2020. All right. When you ask questions on the exam and we need to determine if something is statistically significant or not, depending on the confidence interval having 0 or 1, will you say difference or ratio in the question? Or is there any way to determine if it's a ratio or difference? It's a good question. So if something says odds ratio, it's a ratio. If something says relative risk, relative meaning you're comparing those things, one thing divided by another, that is also going to be another ratio, okay? If I say anything's an absolute difference, if you hear difference in there, that means one thing subtracted by another. That would be the case where 0 is the level of significance. And it's a ratio or it's relative, then your level of significance is going to include 1, okay? If that makes some sense.
Professor?
Yes.
I have a follow-up question regarding the ordinal versus continuous. So in the article that we just went over, the dose you said was ordinal, right?
Yeah, that one's a little more difficult. I could probably consider that. I could construe that as an ordinal variable.
Okay, but so based on the definition of continuous, why would it not be continuous? Because it goes from 28 to 56 to 84, which means it's just like adding the 28.
Yeah, it all depends on the context and how you sort of define it. For instance, if I say I'm going to break things up into categories of low, medium, and high, I could assign numbers to that if I wanted to. I could say 10, 20, 30, but I'm still considering those individual categories. There's no direct relationship between those groups necessarily. It's not like blood pressure where I could run from 26 to 27 to 28, or like for instance, if I did straight dose, I could do 26 milligrams, 27 milligrams, 28 milligrams. It's how the researchers defined it. In that case there, they lump them into categories of you get placebo or you get 14 milligrams, 56, whatever the numbers were. They lump those into categories, which just makes them an ordinal variable, I would say, in that case. The context does matter. I will be clear on the exam though, so don't you worry about that. Everything should be fairly, I think they'll be clear, but we'll see. Let's see. Still need to find a way to cast a rocket movie based on this year and make it into action. Yeah, they probably will. We'll see. Maybe autobiographical. Who knows? Didn't he like rip the gate off of his house one time to this year? You get a movie set or something. Let's see. Even with numerical doses, wouldn't changes in doses be fixed amounts, making it ordinal? Yeah, that's exactly what I was trying to say there because they lumped them into the individual categories there. Okay. Okay, so when is the p-value insignificant when the CI includes 1 versus 0? So that's a good question. So if the CI, so if you're doing like an absolute risk difference, right? So let me just put a sticky note on here just to make it clear. So if you're doing any kind of like difference, absolute difference, anything like that, if it includes 0, then P has to be greater than, or has to either be greater than or equal to 0.05, okay? Versus if we have something like a ratio, relative risk, something like that, if it includes 1, sorry, my headphones are getting in the way. It includes 1, then P is greater than equal to 0.05. I don't know the shortcut for greater than or equal to. Well, slash. How about that? Right, so you can make those distinctions there. So if you see that the p-value is less than 0.05, then you can automatically assume that the confidence interval did not include those numbers based on the type of measure that they're doing. Okay, so I'll leave that there so you can go back and see that. Okay, so without further ado, let's go ahead and get into our review questions. We'll see what we have time for. Do you guys have anything to be at specifically at 2:30? Any chance? If I run a few minutes late, is that going to be okay? You can all leave me if you want to. I'm going to go through these questions anyway, so. Okay. So let's go through this. Let's go ahead and do our review for this stuff. So let's do question 1. Some of these are definition based. Some of these are a little bit more looking at some details of a study. So what is meant by the standard error of the mean? An estimate of the standard deviation of a group of sample means around the population mean. Is it a measure of the frequency of an occurrence over some time interval? It represents a relationship between specificity and sensitivity, or it's a mathematical equation to convert non-symmetrical data into a normal distribution. What do we think? Oh, you have to go to ClinPath. Professor Kaplan, he will understand. This is obviously the much more important class, obviously. I think it's A. A lot of people are probably looking at the notes too. That's okay. That's what they're there for, so you can go back and study for this for Friday. Yeah, so it's the estimate of the standard deviation of a group of sample means around the population mean, right? I think I put in a question. I put in, actually didn't put that in there. I put in animations to actually show the answers there, but I'll leave that for myself so I don't make any errors here. Right, so the standard error of the mean is basically saying like how close is your sample getting to the actual population mean. And remember that, yeah, they're there. Remember that the bigger your sample size is, oh wait, they are posted. Do you guys see the slides or no? Okay, good, you find them. Yeah, so the bigger your sample size is, the closer to the actual population size itself, the closer that the sample mean is going to be. And so standard error of the mean typically gets smaller as the sample size gets bigger there, okay? So again, more definitional sort of question. Here's a good one. So suppose a clinically accepted value for mean fasting glucose in females aged 20 to 29 is 100 milligrams per deciliter, and the standard deviation is 10 milligrams per deciliter. The fasting glucose for a 25-year-old female was 130 milligrams per deciliter, okay? How many standard deviations above the mean is this subject's fasting glucose? What do we think? Right, so think about this, and if you draw it out, let me see here, paint. So if I were to draw this out, again, I did this the other day, but just for reiteration, because I think it's an important concept. So again, if I were to draw out a standard, like a normal distributed sort of curve here, and it goes up, mean in the middle, and then it goes back down. This is a normally distributed curve, even though it maybe look a little crooked or something. So remember, your mean is going to be right here in the middle. This is the 50% mark. Probably should have just done the line. Right, so 50% mark here, and remember your standard deviations will extend out beyond that. So in this case here, the question, what did I say the mean was? I said that the actual mean is 100 milligrams per deciliter. So this value right here is 100, right? And so does that mean every single person within that group is going to measure 100 every single time you measure them? Well, no, there's variability in the data as always. And so you can see that if you go out different standard deviations, you're going to encompass certain numbers of those people, right? So again, as you get further from the mean, you're going to find that the number of people with those values shrinks down because of the fact that you're getting more and more extreme values going on there, right? Oops, let me do that. Be black. Anyway, so again, that should be the same color, but whatever. So again, fewer people should have these extremes here, but the standard deviation gives us a clue as to, in terms of the basically how far away from that mean that we're actually getting there. And if you recall, within one standard deviation from either end, so say from red to red, what percentage of observations am I getting there? 68%, very good. Yeah, so you're gonna get 68%. I keep screwing these numbers up. Oh my gosh. This is terrible. You can tell I'm not very good with this. Right, so within this range here, so between here to here, you're getting 68% of the observations. Most people, about 2/3 of people are going to fall within that, right? As opposed to if I start to go out to say 2 standard deviations on either side, what am I going to get to here? Yeah, so 95% of the observation should be between 2 standard deviations. How about between 3 standard deviations? 99, very good. So you already know what I'm going to be asking here. How do I define what these values are at the standard deviation marks? Well, I have to know what my mean is, and then I have to know what the standard deviation is. So I said the mean already is 100. So if I said the standard deviation is 10 milligrams per deciliter. So what is this red line here to the right? What value is that, do you think? It would be 110, right? So, and again, it's as simple as that. Normally the numbers aren't so clear cut, but it's as simple as that. How about this red line on over to the left? 90, it's simple, right? So for a test, if I were to ask you a question like this that were to come up, I could say, okay, well, if I go out 2 standard deviations, I get 120, If I went out 3 standard deviations out here, then this would obviously be 130, right? So looking at this, I could say, okay, for a 25-year-old female with a level of 130, how many standard deviations above the mean is her fasting blood sugar? I can say, okay, well, she's 3 standard deviations of the way, right? So I know that she is going to be kind of high up on that scale, that very few people like her are going to have that same value. Okay, so something's going on here. Now, the question is, how many people, what percentage of people would have a value greater than her? So again, off to this direction, how many people would have a value greater than that? I think 1%. It's actually 0.5%, because remember, between 3 standard deviations away, it's 99% of people. So that means there's a 0.5% on each side there. So only 0.5% of people would have a value greater than what she had. Okay, so kind of keep that in your mind, be able to kind of equate those percentages back and forth to be able to kind of figure out where people are lying at on this kind of curve here, right? Doesn't mean that they're abnormal, it just means that their values are less likely to occur based on that, okay? I will pick values that are very easy for the exam. No math involved here. You just got to be able to look at the numbers and be able to discern kind of what I'm talking about. So yeah, it should be 3 standard deviations away, okay? I'll keep it between 1 and 3. I'm not going to get more crazy than that, okay? All right, so in statistical analysis, an alpha or type 1 error refers to which of the following? Is it going to be the probability of rejecting the null hypothesis when it's true, probability of failing to reject the null hypothesis when it's false, probability of keeping both the null hypothesis and the alternative hypothesis when neither is true, or probability of rejecting both the null and the alternative when both are true? Yeah, so neither of these ones seem kind of ridiculous. These would not be correct answers here, obviously, because they can't both be true. It's either one or the other in those cases there. So it means the type 1 error rate basically is telling us the probability of rejecting the null hypothesis when it's true. So this is when we would be incorrectly rejecting the null hypothesis when actually we should have kept it, right? So that type 1 error rate is important, because if it's too high, that means our chances of making a type 1 error are too big. Okay, so that's why we set alpha at different levels. If you wanted to be so typical alpha is 0.05. If I wanted to make less type 1 errors, what could I set alpha to? Any ideas? So fewer type 1 errors mean I'd set my alpha lower, so I'm setting the chances lower. So I'd do something like 0.01. Okay, that's pretty standard. So if it's not 0.05, then it'd be 0.01, absolutely less than 0.05. So say type 2 was the more conservative one. So basically anything to reduce your chances of making a type 1 or type 2 error is going to be the more conservative approach. So it's going to make it more difficult to achieve significance. Anytime your type 1 error goes up, your type 2 error typically goes down, and vice versa. If type 2 error goes up, which is that risk of not rejecting the null hypothesis when I should, then my type 1 error is going to go down. Okay, so that's kind of the trade-off between those two, unfortunately. There's no perfect tests that are going to be out there. It's always a risk of making one of those errors. Let's say we suppose a clinically accepted value for mean systolic blood pressure in males aged 20 to 24 is 120 millimeters of mercury, and the standard deviation is 20 millimeters of mercury. What proportion of readings lie within values of 80 to 160? What do we think? B. So how many standard deviations away are we talking about here? So it's 120, and the standard deviation is 20. We can basically say, okay, well, 120 plus 20 is 140. So that's 1 standard deviation away. And then 140 plus 20 is 160. That's 2 standard deviations away. So I'm looking 2 standard deviations away on either side. And I know that within 2 standard deviations, I should get 95% of those readings there. Okay, just like what we talked about before. So see how different ways I can kind of word that question to kind of get at your understanding of the topic. If that makes sense. So B would be the correct answer in this case here. All right. And again, you can stop me if you have any questions, for sure. Using the empirical rule, I already talked about this. What percentage of observation will lie between 3 standard deviations? Yep, yeah, D would be the answer here. So 99, that's as far as we're going to get to on those. 68, 95, 99. Those are good numbers to know. Okay, so if my significance level or alpha is set at 0.05 and the p-value is 0.1 is obtained as a result of the study, what does that indicate? The results of the study are statistically significant. The results of the study are not statistically significant. We are unable to determine whether the results are significant or the results of the study are more reliable than expected. Again, yes, you can go ahead and say, okay, well, these obviously are not going to be true here. We have a p-value, so we should be able to determine something, right? But the studies are statistically significant? No, because p-value is greater than alpha. That's the case here. It is going to be not statistically significant. Now, that could be a type 2 error, but in our case here, we're going to go ahead and say we were not able to find a difference. We cannot reject the null hypothesis. It shall be retained. Okay. The width of a confidence interval is influenced by which of the following? The standard error of the mean, the p-value, the sample size, or the F ratio. Yep, 1000% sample size, right? Sample size does not have any direct impact on p-value. It does not have any effect on, it will affect standard error of the mean, but it's more sample size affecting that than the other way around. But yeah, so confidence interval, if you want to shrink that, you need more or fewer people. You want to shrink your confidence interval. More people. You need as many people as you can to get that confidence interval narrow. Otherwise, it will then expand back out. Because again, you have to give yourself more wiggle room to apply that to the larger population in question, right? Okay. Okay, so this is going to be more typical of some of the questions you're going to see on the test. So you'll have some of those easier ones where they're kind of straightforward, but some of these are going to be more interpretive, right? So you're reviewing a survival analysis study at a medical journal. You note that the study has an N of 200. All enrollment happened in year 1, and the study ran for 10 years. So everyone got in at the same time, which is not true to life, but we'll say it for our sake here. At year 2, 177 people remained in the study. At 2.9, 165 were left. At year 5.8, 100 subjects remained, and then at year 10, only 75 remained. What was the median survival time for this study? Or can we even tell? I think C. Very good. So C would be the correct answer here. Why do we say C? That's when you had half of the patients are out of the study. So once you had half of the patients gone, then that's median survival time. Now, what would be the mean survival time here? Can't know. We need every single person to die in that study in order to tell, right? You'd have to run that study for way too long to be able to figure that out, so we don't know. But that's why median survival times are so helpful. As soon as you get to that 50% mark, then you know, then you can start to make comparisons. Much more manageable to do there. Very good. Which of the following variables is spaced with equal intervals or distances and the 0 point is not considered meaningful? The interval variable, continuous, ordinal, or ratio? So this is a bad question. I meant to change this. So technically, yes, it's a continuous variable, but I want more specific. It's an interval or ratio. How about that? Remember, the important thing here is, does the 0 point matter? And if so, if the 0 matters, then it's going to be considered a ratio variable because you can do ratios with one another. Here, the 0 point is not considered meaningful, so it's going to be an interval variable, right? Double check myself. Interval variable. That means you could have values that are negative, right? You could have someone have a negative, or you go outside and have a negative temperature, right? You can be negative something Fahrenheit. You can't do a ratio of that between, negative 32 versus 60 degree Fahrenheit. That doesn't really make sense. Just like temperature, thank you. Except for Kelvin. If you actually had Kelvin, you could get to absolute 0. You can't go below that. So that would be a case of a ratio variable. Similar, like something like blood pressure. Can you have negative blood pressure? Well, no. So that in that case there, it's also going to be a ratio variable. I can take a blood pressure, a blood pressure going from 50 to 100 is a doubling of pressure. Going from temperature of negative 32 to negative 16 is not a halving of the temperature. So kind of think about it like that. Does the 0 point actually matter? All right. Which statistical test would be best used to summarize a case control study? Do you use relative risk, odds ratio, chi-square, or survival analysis? Ideas. B. What does anyone else think? Anyone agree with Tristan? Be brave and be wrong. That's okay. We're in a safe space here. Yeah, very good. So remember, for case control studies, the typical thing you're going to use is an odds ratio, right? With a case control study, what are we looking at? Well, we're starting off with people with the disease state. Those are my cases. I'm going to grab my controls of people without the disease state and match those to the cases and look backwards to see were they exposed to a risk factor or not, right? And again, those are always retrospective. So they're retrospectively looking back to see, did they have an exposure or not? Did they get a vaccine or not? Did they smoke or not? Whatever the risk factor was. So you start off with the disease, then you look back for the risk factor. As opposed to something like, for instance, the randomized controlled trial we looked at, we started off with the risk factor. We randomized people to either get the S Academy or not, and then look to see at the outcome, change in depression. So again, that's what you need to be looking for here, is how is the study sort of being defined? So odds ratio here. When could I use a relative risk? What type of studies? We could do it for prospective. So we could do it for like a cohort study. They could have done it in that randomized controlled trial if they wanted to. They could have done that. So again, anytime you're dividing the risk of something happening by another, that's a relative risk there, right? Instead, that article decided to do something akin to a risk reduction, sort of like that. Just depends on what they want to do there. We'll talk about chi-square a little bit later. Okay, so a researcher is seeking a statistical test that can determine whether the means of 4 groups are all equal. Which of the following is the best test that this researcher should select? A. Very good. Right. So remember, and keep in mind your parametric versus non-parametric test here, but ANOVA is when I'm looking at multiple groups. And again, am I just using one independent variable or am I using 2? That depends. If I'm just using one independent variable, I could have said one-way ANOVA. If I say like a two-way ANOVA, then that would have been looking at 2 independent measures there, or 2 independent variables there. Okay. And remember, this is an unpaired sort of test here, so all the groups should be separate from one another, and there should be no relationship between them. And then again, I'm just looking to see, are there any differences amongst the groups? Am I looking for a p-value that's less than 0.05, or do I want something that's above that? Yeah, so if I'm looking to see if there is actually a difference there, it'll be less than 0.05. I don't know where the difference lies amongst the groups, but I know it'll be less than 0.05. If it's above that, then I can't say there's any differences amongst them, right? Very good. Okay, so I'm performing a case control study in which you're looking at patients who contracted measles versus control cases that did not, and then determining whether or not they were vaccinated. Which of the following statements would be true? This is an example of a prospective study. Vaccination status is a nominal variable. This is an example of a randomized controlled trial. A relative risk would be the best way to report the efficacy of the vaccine at preventing measles. Some of this we already talked about. I think it's A. I think. Yeah, remember, so again, we're looking at people who had measles versus those that didn't, and then looking backwards to see whether they were vaccinated or not. So in that case, there would be a retrospective study. So we can rule out A. We can see, how about vaccination status being nominal? Why is that nominal? Exactly, you're either vaccinated or not. You could also call that a dichotomous variable. There's only 2 outcomes there. So yeah, so that would be nominal. This would be green in this case here. Obviously not a randomized controlled trial. And then why is D incorrect? What did we just talk about? Yeah, because we don't know the full number of people who are at risk for developing measles or not, we can only use things like odds ratios there. So because B is correct, yes, thank you, Paige. That is technically true, and technically right is always the best kind of right, I think. But in this case here, is because you'd use odds ratios in those cases, right? If you're doing a case control study, so that would also be incorrect. Okay. All right. You're performing a study in which you are randomizing 3 independent groups of patients with an N of 120 to receive either 30, 60, or 120 milligrams of oral Sudafed and measuring mean changes in blood pressure. Which of the following would be true? Performing multiple unpaired t-tests would lead to an increased chance of type 1 error. The null hypothesis would be that 120 milligram dose of pseudoephedrine would increase blood pressure the most. The means of measuring blood pressure does not need to be included in your results, or a 2-way ANOVA is needed to determine if you can reject the null hypothesis. A. So why A? Why do we think that?
The more tests you run, the more likely you're to find something of significance, which is making more of a type 1 error.
Definitely. Yeah, so because in this case here, I'd have to do 30 versus 60, 30 versus 120, and then 60 versus 120. It's 4 comparisons I'm having to make there. And so if I wanted to do something, oh, that's too bad his computer died. I'm recording it, so I'll post it up later if he wants to watch. But because of that, if I wanted to do something like a Bonferroni correction, how would I account for that if I have to do 4 different comparisons?
You divide the p-values between all groups.
So what am I dividing by the number of comparisons I'm making?
So if you had, you have 3 comparisons, then you would divide 0.05 3 times, and then that would be the significance you'd have to achieve.
Yeah, and Celine is correct too. So the alpha is what I'm dividing up, right? Because I'm setting my alpha at 0.05. I take that and divide it by, in this case here, 4 comparisons. And so whatever that ends up being, that would be 1.25 or something. 0.0125, I guess, would be the new alpha that my values have to get less than, my p-values have to get less than in order to avoid a type 1 error, right? So that's if I'm doing multiple comparisons and I want to make sure I'm not going to increase my chance of type 1 error. That's why I do something like a Bonferroni correction. Again, that's the easiest one, but there's a lot of them that are out there, okay? So this one would definitely be true. Let's look at the other options though. So the null hypothesis would be a 120 milligram dose. Why is this one incorrect? Yeah, null would be no change. So it would be basically there's no difference in change in blood pressure despite the dose that they're receiving there. Jonathan was asking, when is relative risk more pertinent than versus odds ratio? Just know if I'm doing a case control study where I don't know what the full population who's at risk for a particular disease, then I use an odds ratio. When I'm doing say a prospective cohort study or randomized controlled trial, I'm setting up what the population is. I'm setting these 100 people that I recruited are going to be at risk for developing cancer or whatever the outcome I'm looking for. And that's when relative risk and absolute risk reductions and things like that are more pertinent. Okay. Let's see. The means of measuring blood pressure does not need to be included in results. You'd want that because you just want to see what the differences would be there. And then I don't need a 2-way ANOVA, although could I have used a 1-way ANOVA on this initially? Definitely, right? Because I could have seen, is there any difference amongst these groups in the first place, and then dug down further to see where it lies. A 2-way ANOVA would be if I did something like the dose of the medication was an independent variable, and then I also included history of pre-existing hypertension. That could be another independent variable that I could have used a 2-way ANOVA for, okay? Okay, which of the following is a non-parametric test used to evaluate non-paired data? The Wilcoxon sign rank test, chi-square, linear regression, or Mann-Whitney U-test. So again, when do we use non-parametric tests? Yes, non-Gaussian or non-normally distributed data, right? So if you did a test for normality on your data and it showed that it was the p-value is less than 0.05 and you said this does not appear to come from a Gaussian distribution, then you'd use non-parametric. Or if you just don't want to, if you don't even want to do it, you could just switch over to use non-parametric. Those are always going to be more conservative estimates anyway, and so you're not going to be wrong to use non-parametric tests. Okay. See, non-paired is 2 words and Mann-Whitney is 2. That's how I remembered it. That's a very good handy point there, Matt. Yeah, so again, D is the right one. Chi-square is going to be more so comparing like expected versus actual frequencies. Linear regression we talked about as being a way to sort of predict one value from another, right? And then Wilcoxon sign rank test is going to be more so for like paired data in some cases there. Okay, so moving on. Which of the following tests is used to assess the observed versus expected findings of the study? Of course, I just go ahead and give it away. Put it in the vault page, but make sure you can bring it back out. That's what I always want to make sure I can do for myself, because I always usually stick stuff in the vault and then I can never find it again. Yeah, so that's a chi-square test. If you recall, we talked about like the firefighters and where they were dying from heart attacks, for instance, depending on which part of their duty they were doing for that day, whether they're exercising or actively responding to a fire or something like that. So we looked at the expected, or basically we looked at what actually happened versus what we'd expect if it was totally random, and then compare those two together to see if there's a statistically significant difference. And that's what chi-square is really good for in those cases there. You could also do it for like ordinal and nominal data there. So if I wanted to do a study of, say I looked at all of you guys in the class and I divvied up everyone, I did male versus female, for instance, and I did what make of car you drove. I could do a chi-square like that as well to see like, okay, well, is there any sort of relationship between gender and the type of car you drive versus is it just totally random? And so that could be another way you could do that. So good for non-continuous data. All right. Which of the following statistical analyses finds the line that best predicts y from x? Is there no 16? Oh my goodness. Well, I hope I didn't hide it. Slide them out now. Nope, I totally just skipped it. Depriving you of a whole question. Maybe I can make up another one later. So which test is best from predicting y from x? Yeah, very good. So again, it's kind of one step up from a correlation where I just look to see how the data varies with one another. Linear regression is how I predict y from x, right? That's the important component there. And recall, if I'm looking to see, if I'm doing a linear regression, I get that r squared value. Again, the r squared value tells me basically sort of the slope of that line for that best fit line. What's kind of like the tightest fit that you could get? What's like the best r squared value you could get where the data points basically are right there on the line? It could be 1, or what could it also be? -1, right? So if it's inversely proportional to one another, you'd have a -1 there, where you can see that 1 point down for x means 1 point up for y. It'd be -1 in that case there. Rarely does it get to be that tight, but just know the closer you are to 1 or -1, the tighter the association means. The closer those points are to fitting on that line exactly, right? So rare you'd ever have that, but you get close. Which is actually, when you're dealing with the linear regressions, what would be the null hypothesis? What would be the slope of that line in that case there if there's no relationship between y from x? I couldn't predict it. Yeah, it'd be 0 or a horizontal line. That's always going to be your null hypothesis for linear regressions. You're saying, okay, there is a relationship here. I want to reject that. And that's what the r squared value can do for you. Okay, very good. What is the most sophisticated method of data measurement? If you had to look at all of these, what would you consider? You had to consider the type of data measurement that best describes you. Sophisticated. Yeah, it'd actually be C, right? So again, the ratio of variables, because I can do the most different types of calculations with it. I can do ratios, I can do subtraction, I can do all of that. Things get more limited as you get into interval, nominal, and ordinal, right? Nominal being the least sophisticated, followed by ordinal, followed by interval, and then ratio. So that's a handy thing to know there. With intervals, I can subtract one from another, but I can't really do things like ratios to them, which is why we call them, that's why they have ratio variables, because you can't do ratios. All right, which of the following study designs is generally accepted as the most reliable evidence that a treatment is effective? I gave this one away too. Also C. I'm starting to see a trend here. That's interesting. Couldn't see. Right, so randomized controlled trials. This is what tells me, can I actually establish cause and effect? This is the most effective way to do this. Which one of these do you think would be the least reliable? I'm just recognizing a pattern, right? I can do a statistical test on it to see if it's true. One of the things, cohort. Now, we didn't talk about this too much, but it's actually going to be D here. So, sort of going in the hierarchical, going from the least sort of ability to tell cause and effect all the way to the highest, you start out with a case report. Case report is just describing one patient. It could be a 1 in a million thing. It could have a total fluke. A case report doesn't really tell you a whole lot, but it gets you curious. And so from there, you can do a case series, which is where you have several people who, maybe have, maybe 2 to a dozen in a case series, all describing what their experience with whatever. I'll tell you what, case reports really easy to get published as compared to everything else, because you just basically describe the patient, you do a little bit of lit review. Any one of you could get a case report published off of rotations. Actually, that's what I did when I was on rotations. So you could do it too if you wanted. So then a step up from case series is going to be what? Anyone know? It's on the list here. Yeah, then it's going to be case control, right? Because again, I'm already starting with people who have the disease state, matching with people who don't, and then just looking backwards. It's all just data review. So I'm not actually doing anything there. Next is going to be cohort trials, where again, I'm watching to see what's happening. I'm divvying up people based off whether they have a risk factor or not and then following them, but I'm not having any direct intervention. I'm usually just watching to see what happens. So you can look to get better ideas about cause and effect, but nothing concrete. It's not until you get to randomized controlled trials that is where you get the best evidence. So kind of hit that hierarchy in your mind. So when you're doing research and you're looking at articles, you can kind of get an idea for kind of where it's falling on that spectrum there, right? Okay. Which of the following tests makes no assumption about the population distribution? Parametric, non-parametric, chi-square, or normality test? Very good. Yeah, so it's going to be non-parametric tests. So again, it does not make any assumptions. And again, they're more conservative tests, meaning it's harder to achieve significance, but your type 2 error goes up, but type 1 error is relatively low. So that's kind of the nice thing about that. Parametric tests assume that you're using a Gaussian distribution, a normally distributed set of data, and you can confirm that by using normality test, right? They'll tell you whether the degree of variation you see in your data is likely to be due to from a Gaussian distribution, or it's very unlikely to be from a Gaussian distribution. And then chi-squares we talked about just being a frequency counts basically. All right, so let's say we're reading an article in which the investigators wanted to compare treatment with a new diabetic medication with placebo on fasting blood sugar. The researchers randomized 40 patients to either receive placebo or drug X. The researchers used a paired t-test and found that patients in experimental group had a mean difference in fasting blood glucose of -10 milligrams per deciliter with a confidence interval of -21 to 7. Which of the following conclusions would be correct? Actually, it should be unpaired tests because the groups are unrelated to one another. We could say the results are clinically and statistically significant. Researchers may be making a type 1 error. Researchers are using a paired t-test correctly. Actually, no, I should have left that alone. That was part of the answers. Haha, just kidding. Or researchers may not have enough power to reject the null hypothesis. What do you think? I think B is the correct answer here. All right, why do we think that? Why could that be? So looking at this, remember, it's a mean difference, right? So again, we don't know what the standard deviation is, Caleb. We know what the confidence interval is, which is fairly wide. But looking at this here, you can see that with the confidence interval, we're looking at a mean difference. So if there was no difference, then it would be 0. So in this case here, because the confidence interval encompasses 0, we cannot say that this is statistically significant. The p-value would be greater than 0.05. Okay, so in this case here, the researcher may be making a type 1 error. If they took this data and said, look how great this drug is, it reduces blood sugar, not really, right? Because it's not statistically significant. Now, let's say that this did not include 0. Maybe it was -21 to say -1. Would this be a clinically significant difference to you? Placebo versus this new drug, brand new drug, only dropped your blood sugar 10 points. Would that matter to you? Probably not, right? Not really, especially if you're talking about diabetic patients and they're up in like in the 200s or something. Not gonna do a whole lot of good. So I probably would not consider that clinically significant either. Okay. Now, did the researchers use a paired test correctly? No, because again, these groups are not related to one another. And they still couldn't even find a difference. So it tells you there's probably definitely nothing here. The researchers may not have had enough power to reject the null hypothesis. So they may be underpowered, right? So if you look here, if they had more people to include in the actual study itself, then perhaps they could have found a difference there, but it may be underpowered. Okay. Now the type 1 error would only be if they falsely rejected the null hypothesis here. So this probably isn't the most clear answer, but trust me, the test is gonna be a little bit better. Yeah. So if the researcher said this is a great drug, this is great, statistically significant, they'd be incorrect. That'd be a type 1 error. They would be falsely rejecting the null hypothesis. But again, in this case here, because they did not find a difference, it could be underpowered. So I'll be more clear on the exam here, but this is D would technically be correct, but B would be kind of more situational. That makes sense. Okay, so you're reading an article in which the investigators wanted to compare treatment, the same example here. So looking at this, so fasting blood sugar is a confounding variable. What do you guys think? Is that true or not? Let's go through the other ones too. So whether the patients receive drug or not is a dependent variable. Adding a third group receiving a different dose of drug X would require a use of ANOVA, or fasting blood sugar is an ordinal variable. What do you think about these? So first off, fasting blood sugar, do you consider this to be an ordinal variable? That would be continuous, right? Because again, there's a 0 point. Could you have negative blood sugar? No, it's definitely continuous, so that would definitely not be the case here. So I don't rule that one out, okay? Now again, what's my outcome measure here? What's my dependent variable? My dependent is the mean difference in fasting blood glucose. That's my outcome. So this means that fasting blood glucose for these groups is my is my dependent variable because it's dependent on whether they got the drug or not. So in this case here, is fasting blood sugar a confounding variable? Well, no, because that's what I'm actually measuring. So in this case here, this would be incorrect as well, right? So whether the patients receive drug or not is a dependent variable. Well, we said no, it's going to be independent in that case there. So instead, what do we got left? If adding a third group receiving a different dose of drug X would require the use of ANOVA. That can be helpful because then instead of just making a bunch of comparisons, you can then compare the three groups together and see if there's any difference, and then you can kind of go from there if you need to do further comparisons, which I think is what I put in there. Yeah, put C. So I got it right? So make sure you can kind of look at the different factors here in the vignette and be able to kind of identify these as like yes or no kind of things for questions like this. All right, so last couple of questions here. So let's say we're performing an experiment in which you take a random sampling of PA students and then I randomize them into two groups. One is exposed to radioactive waste while the other is exposed to placebo. And then I follow the two groups to see who develops superpowers, right? The results are in a table above, or actually below. What are the following can be correctly concluded from the study? Okay, so you can see here, you got the experimental groups. I took 32 of you, and then 31, I guess there should be 31 and 31 since there's only 62 of you. But regardless, we can see here that 23 people in the experimental group got superpowers, 5 did not, or 5 did in the control group. There's no superpowers here at 9, 26. And so looking at the absolute risk of developing superpowers in the experimental group was 56% with a confidence interval here. And then you can see the relative risk here in terms of relative risk of developing superpowers, right? So anyway, so let's look at this. So the study is underpowered to detect a difference. What do we think? Think yes or no? Think no? So it's underpowered. So did I find a difference between these groups here, right? So looking at this, because I have a relative risk, so I'm comparing the experimental group to the other, is this a statistically significant result? So the group in the experimental group are 4.5 times higher to develop superpowers than the ones in the control group. Well, that is statistically significant because I'm doing a relative risk. What do you notice here? It does not include 1. So I can go ahead and say that, yes, I can reject the null hypothesis and say that by showering all of you in a radioactive waste would be more likely to give you superpowers than not. I'm not going to do that. The class of 2016 really just never forgave me for it, so I'm not going to run that one again, okay? But science is what the science is. Exposure to toxic waste increases cancer risk. Can I say that from the data presented here? I cannot because I didn't look at that as an outcome, so I have no idea, right? An unpaired t-test is an appropriate test for this experiment. What do you think? Yeah, because presuming I don't have any relatives within the class, there's no siblings or anything together, then yeah, you guys should all be independent from one another. And so that would be an appropriate test in that case there. So C would technically be correct in this instance here. And then exposure to radioactive waste is more likely to lead to flight versus X-ray vision. Could I say that? No, I'll probably need to do some kind of secondary analysis to see what type of superpower was actually developed after exposure to the radioactive waste, right? All right, how about this? So multiple comparison corrections should be used in this experiment. Well, not really, because I only did one comparison. I compared the experimental group versus the control for this one outcome. So in this case here, I would not really need to do multiple comparisons, corrections there like that. I would if I was doing like multiple outcomes, but in this case, no. Students with superpowers already should be an exclusion criteria. What do you think? It should be, because if you have pre-existing superpowers, then you could be skewing the data one way or the other. So in this case here, just being super smarty pants does not actually count. I would not include that as an exclusion criteria, although most of you fit the bill for that. I think all of you do. Would this be a retrospective study? No, because I actually, this is more of an interventional experimental study. This is what I'm looking forward in the future is prospective to see what happened there. And then development of superpowers is an ordinal variable. What do you think? No, right? Because it's a yes or no sort of thing. It's like dichotomous nominal variable there. Had I broken it down into different types of superpowers, that would still be considered nominal. There's no way to really sort of categorize one being better than the other, although flight would be pretty awesome as compared to some other superpowers. But again, not defined here. So that's the review. That's the sort of questions you're going to find on the exam. I try to keep them more serious on the test than I do on the actual review. But let's see if there's any other questions. And again, I'm done on plenty of time. That's just fantastic. Okay. So someone's asking, can you briefly explain standard error of the mean again? I have been had trouble understanding what it means. Basically, it's saying how much your sample how much it differs compared to what the actual sample or the actual mean of the population would be, right? So how variable your sample mean is versus the mean of the population. And so it gives you some degree of variability, but it is a bigger sign of your population size or the sample size that you had, such that the bigger sample you have, the more closely approximating what the actual population is. So as you get that number bigger and bigger and bigger, it's more closely getting to the actual population in question. And so your standard error, that mean should get closer and closer and closer to the actual population mean. So a bigger sample size helps to reduce that standard error. The mean gets it closer to the whole population mean. Okay. All right. Talked about that. Why would answer to question 12 be nominal? According to the lecture, why would nominal be more than 2 possible outcomes? Why wouldn't binomial be a better option since its definition 2 distinct possible outcomes like vaccinated or not? So both are correct there, right? If I'm just naming something, even if there's only 2 variables, that's still considered nominal. But you could call it binomial, you could call it dichotomous. That's just being more specific, right? So just being more specific to say there's only 2. I would never have a test question where I have you delineate between a dichotomous variable versus nominal. That would be kind of rude because they're both correct depending on the situation. So all dichotomous variables are nominal, but not all nominals are dichotomous, I guess you could say, right? So could you explain what absolute versus relative risk is again? Yes, I can. Let's see here. So going back to this, when you're looking at the absolute risk versus not. So again, basically what you're saying is that the risk of something happening versus it not happening or risk of something happening in one group versus another. So in this case here, what I could do is take the say if the percentage of something happened. Actually, I'm gonna do draw something out or just write it out, I guess. All right, so let's say I have group A. Here's my font. So you have group A, and then I'm going to have group B over here. And then this group, they get experimental drug. And then this group here, they get placebo, right? And so my main outcome I want to look at is death, okay? And so I can say here that death was only happened in, say, 40 out of 100 people. And then over here, death occurred in, let's say, 60 out of 100. Okay? So looking at that, what would be my risk of death in group A? Again, I know what the defined population is because I know it's only 100 people in each group. So in this case here, the risk was 40 out of 100 or just 40%, right? Similarly, in this group here, I know the risk of death in group B is going to be 60%. Pretty straightforward so far, right? So what would I be able to say? So that's, again, that's the... So on the other hand, though, what if I... Oh my goodness, getting all screwed up here. So looking at that, so there's a risk of death in each of the groups here. If I were to say what is the absolute difference in risk of death between these two groups, basically I would just take the 40%, subtract it from the subtract negative subtract 60% from that, and I can see that my risk of death is negative 20%. So that's the absolute risk difference between these two groups. Because the people in group A were more likely to live, this risk is a negative because more of them were likely to live there. So there's an absolute risk difference of negative 20. Just like when we saw people's depression got better in the study we were looking at, the values were negative because the actual depression was getting better and the numbers were going down in those cases there. Okay. Also, what could I do here? Well, I can get a relative risk as well. So I could say, well, looking at this, the relative risk would just be 40% divided by 60%. What does that equal out to be? Well, it's about 2/3, right? So it's about 0.66% here. So I can look at this and say that there was basically a relative risk of only 66% of, actually that's, shouldn't have. I can say that there was a 66% chance of death in the experimental group versus the placebo group, meaning that it was 1/3 less, right? So I'm looking at the relative risk versus the absolute difference in risk, okay? So this is relative risk, and this would be absolute risk difference. Okay. And then I could also have like confidence intervals to go along with that. So in this case here, if it was going to be statistically significant, I would say it could range from like negative, say 28 to, let's say, negative 5. Okay. And so in that case there, because it's going from negative 20% to, and it can range between negative 28 to negative 5, I would still be able to conclude that this is statistically significant because it's an absolute difference. If this included 0, it would be statistically, or if it did not include 0, it's statistically significant. If I said, okay, it went from negative 28 to 7, now because it includes 0, it is now not statistically significant. Okay, that makes sense. On the case here, because I'm doing a relative risk, because I divided one by the other, basically what I can see here is that this could have also a confidence interval that range between, let's say, 45% all the way to, say, something like, 78%. Now, the other way, if I can get this right, the other way to put this would just be to do like 0.45 to 0.76, right? That'd probably be the more accurate way to describe that if you were to read the literature, 0.66. So looking at that, would this be considered to be statistically significant? Well, yeah, because I did a relative risk. If these were the same, then it would be 1. So in this case here, because this does not encompass 1, then I could not, because it does not encompass 1, I could say this is statistically significant. Now, if it said it went up to like 1.02, even though it just barely covers 1, it still does, and so I would not be able to reject the null hypothesis. There's some degree to where if I applied this to the population, that some people could be at an increased risk for death, right? It's a possibility. So it really depends on the confidence intervals, how those get reported out, and that's how you can make those differences there. So hopefully that makes some sense on how we could actually calculate those things out using relatively simple numbers. Okay. Okay. So hopefully that makes sense. What other questions do you guys have? This is actually like finishing right on time. Hopefully I made it clear. Hopefully I gave you some good ideas about what test questions are going to look like on the exam on Friday. Anything at all? I see the steam coming out, so I'm assuming everyone's like, I'm going to look at this later. Hopefully it'll make more sense. So the PowerPoint is posted up. Yes, I agree. This stuff is difficult to internalize. Once you get it, like, it makes a lot more sense. And doing things like journal clubs and rotations definitely help to drive a lot of it home. I will post up the video as well, so I'll put a link on there underneath the PowerPoint later on today, so that way you get you can watch it again if you like. If nothing else, you guys are free to go. I'll stick around for a few minutes to see if anyone has questions, but thank you all for joining me.
So I still have like a question about the relative risk thing. I just
Yeah.
didn't want to hold like the rest of the
Oh,
class.
no, you're fine.
So does it mean in your example that group A is 66% less likely to die with the drug than compared to group B?
So it means that their risk is only 66% that of group B, right? Because we saw that there was a definite decrease in risk of 40% versus 60%, but if you were to actually get the relative risk, it's only 66% as much. And this gets really confusing when you're looking at like a lot of, when you look at the news and they say, oh, look, there's a relative risk of 0.66, meaning like some people would take that away to be like, oh, well, I only have, 0.66 chance of dying from this, which is not accurate, right? There's still a 40% risk of death here as compared to 60 in here. It's just that this 40% is 66% of 60, right? And so it gets to,
Oh, okay.
yeah, so it's really just getting the relative, the ratio here between 40 to 60%, which is how I got those numbers there.
Okay.
That makes some
As in,
sense.
this isn't comparing it to the population at all, the hypothetical population.
So this would be, if I were then to take this number and if I were to then expand this out to the whole population, if I gave everyone, this drug, then their actual relative risk of death, and actually if you look at this, the actual risk reduction, actual risk would range anywhere between, say, negative 28 to 7. So it could be some people potentially, or if I apply it to population, it could be some world where 7%, actually had a 7% increase in risk of death, right? Because it had such a big confidence interval here, versus here, Basically saying that your risk of death could actually go 2% above the baseline, 2% above the 60%, because this is considered your baseline because it's the placebo, right?
Yes.
So that's basically what it's saying, that
Okay.
your risk of death as compared to placebo could actually go up 2%, or it could go down as low as 45% as much as placebo.
Okay, thank you.
Yep, it's a little confusing, but the more you look at it, the more sense it sort of makes. And there's videos online too. If you, there's some Khan Academy videos out there might do a better job of explaining it than me, perhaps. I don't know. Some people like that stuff better. You can check it out.
Thank you.
I have a question,
Yeah.
and hopefully I'm remembering this correctly. But when we were discussing the journal,
Mhm.
the sample size, you mentioned something about the type 2 error being related to the sample size. Like you're more likely to make a type 2 error.
So the more people you include, the more power you have to detect a difference. That generally lowers your risk for making a type 2 error if you include more people, right? When they did the sample size calculation here, they said, okay, sample size is determined based on the following differences between intranasal ketamine and placebo. So they looked at the scores that they wanted to find. That's called effect size. If you were to look up sample size calculations, you'll see that term there, effect size. They wanted to find a 9-point difference. Now, do you think it's harder to find very small differences or harder to find very big differences?
Big difference.
Well, if you think about it, if you went to go look for, do you think it's harder to find, like if you went to your garage, is it harder to find a big old chainsaw sitting or the lawnmower, or is it harder to find like a single screwdriver?
Oh, okay. So yeah,
Right?
the smaller
So
one.
really big differences between groups are relatively easy to find. I don't need a whole lot of people for that, but relatively small differences, then it gets to be more challenging. In those cases there, they only want to find a 9-point treatment size difference, which seems, depending on if you work in behavioral health, maybe that's a lot, maybe that's a little, whatever the case may be, that's what they chose. So that's their effect size, right? So then they were going ahead and they said, based on results of previous studies, which helped them to make future determinations, right? It's estimated 40% participants would have a moderate score here, severe score. And then they did some other assumptions here about sample size calculations. And again, they wanted to get this much power. So they assumed what their standard deviation would be as well based on previous studies. And again, some of this is outside of our scope. And then they figured out what their alpha is, right? That also factored into it. So all of that basically calculated out to say we need 60 people in the study, right? That way it gives you an adequate relationship between not having too big of a type 2 error risk and not too much of a type 1 error risk. That's where their acceptable medium is for that. And they talked about type 2 later as well. Yeah, so if you look here, they talked about how in their discussion, so the design allowed for smaller sample size to assess efficacy, dose response, and safety than a standard parallel group design, which preserving the low chance of type 2 error to avoid missing any efficacy signal. Meaning that they didn't want to accidentally fail to reject the null hypothesis if there really was a difference there. So the way they designed the study helped them to mitigate that risk. And again, a lot of the stuff to see if it's even if it makes sense. That's what the peer review process does too. People will look at this and be like, "Wait, that doesn't even make sense. You can't really say that," you know.
Okay, so in essence, you're saying that the larger the sample size, the lower the chance of the type 2 error.
Generally speaking, yes, because you have more people to actually show the difference. You have more power to show a difference.
Okay, thank you.
Mm-hmm. Any other questions? All right. Well, you guys have a great day. And if anything that comes up, just email me and I'll see how you guys do on Friday.
Thank you.
See ya.